issues. Let's see. No, she's not in the waiting room. Okay, so we have 2 chapters left. We're going to talk about chapter 13 today. We will talk about the discussion section of our paper on Friday and what's expected. And then on the 20th, I will probably do group sessions again, just like we've done before, group meetings, to just check in to see how we're doing with the discussion, what's the expectation and all that. And then we will wrap up all lectures on the 23rd. As a reminder, there will be no class on the 27th or the, 30th. That is the week that the final exam will be held, and your paper will be due by midnight on the 30th. So that paper should be all the sections that you've written so far kind of smushed together into one document, and then you're submitting that as your final paper. Okay, so that's the lay of the land. 2 more chapters to cover in terms of material. Then the exam will go live. I'll probably just have it go live on Monday, the 26th, and have you guys take it at your leisure. It's one of those that I recognize you guys have access to a lot of resources. My hope is that you are able to, just make sense of it. So just be prepared for the exam. There's going to be a lot of application of what we've learned. So it's not going to be rote memorization, like, what is this? What is that? Like, what's a moderating effect? It's not really what we're doing. It's really more applying everything that's been learned. Because again, that's the goal of the class, that you guys can take away what you've learned and then run research in the future. Questions about the remainder of our class? That'll sound good? Okay, so why don't we take a moment and let me plug in groups for next week, the 20th, which is right here, I think. Okay. 4:20. All right. Who wants to be my 9 a.m. group? Should we just stick it the way we've been doing it before? Okay, so Sam, Ashley, and Mara? Okay. (9:30) group. Was that you, Grace? Were you guys a 9:30 group? Or was it Haley? Or Elizabeth?
We're the 10 o'clock group.
Okay, Grace, who's in the 10 a.m. group? It's you. Is it Greg?
Me, Abby, and Greg.
Yep, that's me.
Greg and Emily?
Abby.
Abby. Okay. Like there's a lot of folks missing today. So. All right, who's 9:30 group?
That's Liza, Ada, Haley, Emily, and Cammie.
And Cammie?
Yeah.
Perfect. All right. I think we've got everyone, right? Or no. There's 10:30. That's Zach, Saga, and Olympia. Okay. So just like we've done before. Oh, I always do that one. Like we've done before, we'll just log on as the class begins. Be prepared for that one to have your results section so that we can make sense of what the data means. And then I'll walk you guys through on Friday this week, what is the structure of discussion section? What should it look like? So you have that, and then we'll interweave the information you have to fit the structure. Sound good? Okay. So today we are covering chapter 13, which I think is pretty cool because it's essentially what we just did. It is a quasi experiment. Oh, there's Ada. Sorry. I'm not sure I got her in. Let me just double check. Oh, yes, she is. Good. All right. So quasi experiments and small n designs are still important, right? What might be a reason why you go and perform one of those research experiments, like a smaller group design? Why might you do that?
Maybe for like your company or business or something like that.
Okay, so maybe just genuinely you're just interested in a small group because that may be the entire population actually of who you're looking for, right? If it's a small company. Okay, good. What might be another reason?
Maybe you have I think we talked about it in other classes where you have a very targeted population that you're trying to study. So therefore your study is smaller because you're looking at specific variables.
Absolutely. And a prime example of that right now are studies done on specific groups of COVID positive patients, right? So if you're interested in seeing how does COVID manifest itself in children 10 and under, you're not going to be able to have 500 participant, which is a good thing, right? It's going to be a much smaller group. Similarly, when they do transplant studies to see how people do with certain medication, they're not going to have hundreds of participants because that's just not feasible. The number of folks who fall in that category is quite small. Now, the quasi-experiment piece is that you may have a control group and an experimental group, but you didn't necessarily take the same steps that you would need to take in a normal experiment, meaning there's possibly no random sampling, right? It's possible that that's just not feasible based on what you're studying. It's possible that the treatment group is not really treatment, and we'll talk about historical data with that and how that looks. So anyway, there's definitely some possibilities there with that. Okay, so let me just, I have, okay, there's a student trying to get in that doesn't have an internet. Did somebody make it in? Did you make it in? Oh yeah, she's right there. Okay, I was texting you back, never mind. Okay. So here it is. So quasi-experiments, again, we just talked about that, how they differ, and small n designs. Again, sometimes you just have to use that. So we will speak specifically on a few examples for these. So there's two examples of independent group quasi-experiments, some for repeated measure, and then we'll talk about the internal validity piece. So internal validity is, again, we're concerned with establishing causation, right? Experimentation is more towards causation, whereas if you run a survey or a specific study, you're looking more at correlational design, right? An association claim. Quasi-experiments, though, because we are looking for causation, it's harder to deal with threats to the internal validity. It's harder to manage those because you can't necessarily do, remember what we talked about, checking in for maturation, checking in for historical context threats, checking in to make sure that there is a control group. In quasi-experiments, it's more challenging because it's not a true experiment. So your question is always, what is my goal? What am I trying to learn from this study? So is it, in fact, really a necessity that I need to go down the quasi-experiment route because I'm looking at a specific groups of individuals and participants that's really all I can do? If not, then why am I not doing a true experiment? Because obviously those are just stronger in terms of validity and reliability. Lastly, quasi-experiments are not the same as true experiments, like I said, but are they actually just a correlational study? And in some instances, that line gets real blurry as to whether it's just correlational or whether you can access causation. And we'll see a few examples of that, and you'll see the graphs of it. And again, it makes it questionable as to whether it falls in that camp. Okay. So two of the examples of independent groups, quasi-experiments that we'll talk about. First is the Head Start study, and we'll dive into that in just a minute. And then the other one is the psychological effect and impact of cosmetic surgery, specifically with self-esteem. Now, both of those studies are using non-equivalent control group design, okay? So there's at least one treatment group, which is the one that is either getting the surgery or receiving the Head Start program. But unlike true experiments, there is no random assignment to either of those groups. So remember we talked about that being kind of an issue, right? So if participants are self-selecting in a certain group, that may bias your result. Remember we talked about the intensive autism treatment before? Like you can go 5 times per week. Well, certain people didn't have access to that because it was too far. They didn't have the transportation. So then, yeah, maybe you're seeing increased reduction in symptoms or increased ability to adapt. But is it because of the intensive treatment, or is it because those individuals or something unique about them that they had the ability to donate more time, let's say, to the treatment? So something to consider. All right, so the Head Start study, are you guys familiar with Head Start? Is that something you've heard before? Okay, it was a political move that was the idea that if you had children participating in preschool-like activities and settings at age 4, that they would perform better. And this was especially true in lower socioeconomic status communities. So it was government funded, and researchers, now this specific study that I'm showing you results for is from a long time ago, but they were trying to see if there's an effect on that program and overall academic performance later on in life. So these are the SAT scores comparing those who had been in Head Start and those who had not, okay? So what are we noticing from this graph? What do you see from these results?
The people who had been in Head Start scored lower.
Yeah. So again, this is not something that it brings me back to the GRE study prep group, right? They performed worse than those who just received a free pep talk. That's not going to be part of your advertising, right? No, you're like, oh, this didn't quite work out the way we thought. So, okay, so something we need to be mindful of, again, is there was not random assignment, okay? So students who had been in the Head Start program versus those who had not, right? There might be inherent differences about those two groups, right? It's not like we pulled people from the same area and then said, you're going to get Head Start, you're not. No, we're going to follow you till you're 17 and we're going to compare your SAT scores, right? There's also kind of a lot that happens between age 4 to the time where, when are you taking the SATs? Is it junior year of high school? I think it was junior year. So 16, 17, that's a long time, right? So academic achievement, it could be impacted by Head Start, but there's other factors that might get impacted, right? So perhaps we can point to Head Start as being a failure in terms of a program. What might be some other ideas as to why it may have landed that way?
The socioeconomic status of the individuals.
Yeah, I think that's a huge factor, right? So if those who had been in the Head Start program, which is a government funded program, let's say they stayed in the same socioeconomic group, what are the chances? And again, I'm hypothesizing here, I don't know the answer, but what are the chances that they were then allowed or paid to go into an SAT prep class, right? Versus those who maybe hadn't received the Head Start program, maybe there's some of those opportunities, right? And then continuing on, depending on their community, what schools did they go to and how well, Head Start is just one small program when they're really little. The rest of their academic career in primary school and then high school, that is really going to shape their academic achievements, specifically as measured by the SATs. So what did that look like? So again, this would fall in the quasi-experiment piece because we're seeing this issue, right? Like, it was not a matched, it was not a randomly assigned, participants weren't randomly assigned. So you're looking at somebody who's already received this program versus those who didn't, and you're ignoring several other factors. Okay, so that's the first example. The second example is a study that came out in 2014, let me see, 2013. And it's the premise of it is that one of the main reasons people state that they want to have elective cosmetic surgery is to improve self-esteem. So they would feel better about themselves. Inherent to cosmetic surgery, there's not a medical need for it, right? If there is a medical need, then it falls under a non-elective medical needed surgery. Cosmetic elective surgeries would be something that you're just doing to change your body to make you feel better about yourself, right? So researchers said, well, let's see, what does that look like? Does it actually increase their self-esteem more than a control group? Okay. So could you do random assignment for that? What do we think? No. Ada, you're shaking your head and you are correct. So if all of you guys were my participants for this study, then it'd be like, Samuel, no surgery. Mara, we're going to give you a nose job. Ada, no surgery. Ashley, you're going to get calf implants, right? Like, no, that's not happening. We're not electing, and I just picked random things. This is not me saying anything about your face or body, just to highlight the ridiculousness of this, right? Like, you cannot randomly assign people to these categories, right? So because of that, you're inherently looking at a quasi experiment. Okay. So the comparison group is not just random individuals on the street, right? Because then they're entirely different, right? It might be somebody that's quite psychologically healthy and just think they're the best people on earth. So the comparison group were people who had registered for a very similar plastic surgery, but had elected not to do it. Okay. So this was actually quite clever of the researchers, right? Because they're picking somebody who inquired about it, took some steps to meet with a doctor, a surgeon, to discuss getting the surgery, and then ultimately decided, nah, I don't want to do it. So the idea is, what is the motivation behind people trying to schedule these surgeries is that there is maybe a self-esteem deficit, okay? Now, what can we see with the results both at baseline, this would be pre-surgery, and over time? What do you guys notice?
They have the same self-esteem at baseline.
Yeah, so this would be an example of pre and post test, right? So the pre-test, before they had the surgery, both groups had a similar self-esteem. Okay. And then what do we see happens after the surgery, or over time, I should say?
After 3 months, it significantly decreases for the comparison group, their self-esteem.
Okay. And what about the surgery group?
Their self-esteem like increases
Okay.
a lot more than those who don't get the surgery.
Right. Now, if we were to erase that comparison line, right? Just let's ignore that yellow line for a hot minute. How much of an increase are you seeing in self-esteem for the surgery group?
Just slight, not very much.
Yeah, just slight, right? So again, if the main motivator is going to be, well, people get surgery because they increase their self-esteem just massively, would this study and this data support that? We don't know whether it's significant or not, but eyeballing it,
I would say no.
yeah, it seems like the increase is very minimal. The increase in the surgery group is smaller than the decrease in the comparison group, is what it looks like to me, right? If we look, that's like, it looks like maybe 4 points, harder to get a good sense on this graph. And these were self-report measures on how they felt about themselves. They actually had 2 other things they looked at: life satisfaction and general attractiveness. And they showed a similar pattern of that. Your textbook, right here, Oops, where are you? Can you guys see this at all? Okay. So you see this graph, which is very similar to what we just saw. The second one is for life satisfaction. And then the bottom one is general attractiveness. Okay. So we see a similar pattern where the surgery group is higher than the comparison group. But again, it's not a massive difference. I didn't include, oh, I did include, you guys, I'm an idiot. Boom, here they are. Instead of me showing you the textbook like a rando, I didn't think I'd include these slides. There they are. All right, so again, we see a slight change. This is a 0.5 difference on the y-axis. So let's be mindful of that. This is not a huge, variability. And then in terms of general attractiveness, the surgery group showed a steady increase in how they felt about themselves. Whereas overall, the comparison group showed a steady decrease in their sense of general attractiveness. Is any of this surprising to you, or I don't know, what do you think about this study?
I was just talking to Maura, but like I feel like those who get like the cosmetic surgeries, like once they get one, they like continue like, oh, I want this, I want this. So they're constantly like seeking to like kind of feel better and like judging themselves that like, oh, I can fix this, like I want to fix this, stuff like that.
That has definitely been an observed trend where you get one surgery and then you start thinking, what else can I fix? And there becomes often this hyper focus on all the little flaws, which impacts then your emotional well-being. So you may get this initial bump, but I think it's often followed by a decrease as you start looking at something else. That's not necessarily true of everyone. Some people just get the one and it seems to be good enough, but there is definitely that general trend out there and I mean, I feel like there's a celebrity years and years ago on MTV, years ago already when they stopped playing music. Was Heidi somebody? And I mean, I just saw her recently at the grocery store on a magazine and I was like, that's the same person. And the amount, and she looks like a different human. It just is very shocking. Okay, that's neither here nor there, but all right. Two examples here. Those are again, quasi-experiments, but now they're having to do with repeated measures. So they're not independent like our last two examples. These are repeated measures. So the first one, it has to do with food breaks and parole decisions. So judges, obviously they sit on the bench and hear cases all day long, right? The researchers were curious about what is the rate of parole decisions based on how hungry the judge is, right? So if you get close to, 11 a.m., are the judge's decisions different than at 9 a.m. or 1:30 p.m., okay? So this idea that blood glucose levels being lower would lead to a decision fatigue or a pattern of just wanting to be done with the day, okay? Which is is that upsetting to you guys? Because I'm like, hey, personal decision, like personal factors shouldn't impact your legal decisions, but we're all human, right? Okay. And then the other example we'll talk about is television access and crime rates. So there was a period of time, and this I didn't know until I read it in your textbook a couple years ago, but there was a period of time where there are no licenses, or the FCC, I should say, stopped issuing licenses for televisions, specifically for like broadcasting. So then there were parts of the country that had no access to TV. They just didn't have it. And then obviously there are other parts of the country that did. So they were curious during this period of time. Again, there's no random assignment. You're not like, and you get a TV and we pull your TV, right? It doesn't work that way. But they looked at different geographical regions and they were observing crime rate to see if having access to television increased crime rate. Specifically, I think they were looking after larceny. We'll talk about it in a minute, versus not. Okay, so that's their hypothesis. Again, neither of these fall in a normal experiment, right? Because you're not going to say to a judge, you fast all day, and you, sir, the next, again, it can't be a different judge because then there's inherent differences, but that's why this is a repeated measure, then seeing how they do after they've eaten. So, okay, this is the way it's set up. So, here's the results of that. So again, the proportion of favorable parole decisions, this is how they were made before and after food breaks, okay? So again, favorable decision, you could start at the first part of the day, and what do we notice? Sharp decline as they get hungrier, right? This is right after lunch break, sharp decline to the last case of the day. Here, there's another, adjournment for break, and then all the way down. Okay. So this was specifically, let me read to you some of the pieces. This was prisoners, so this was not done in this country. It was prisoners that came from 4 major Israeli prisons, and the parole for these prisoners were rejected 65% of the time on average. But whether or not they came before the judge before or after they had had a break, the judge had had a break, I should say, made a huge difference in terms of whether it was a favorable decision or not. Okay, so because again, here's break 1, here's break 2. We see favorable decisions go way up at the start of the day and right after a break, compared to a sharp decline as the day moved on. Okay, so again, this is it shows the proportion of favorable decisions, just as said that, declines rapidly after a break occurs. So they propose that this is because the break gives time for mental rest and the food is restoring your blood sugar, right? So would this be a causal claim? Being hungry causes you to be harsher in your parole decision? What do you guys think?
I feel like it's harder to say because there's multiple factors that could go into it, but it seems like it is showing that maybe people, because you get like hangry, maybe that affects people's decisions and makes them that they just want to get going with the next case.
Yeah, I think you're absolutely right. I mean, again, if you're hungry or tired, you're mentally fatigued and you're not able to take in information and be as good as when you're fresh off of a break, mentally rested, belly full of food, although not so full that you're like ready to pass out, right? Kind of a good even balance there. But these numbers certainly would suggest that, right? Now, we can't have a control group for this because we can't compare it to another judge who is either snacking all day long, right? That's not going to be helpful either. Or a judge who only works in the morning. So this is why this is a quasi experiment, because there is no inherent control group. Plus, as I mentioned earlier, 2 judges, same situations, may have completely different views on how their legal decisions are made just because of their points of view. So you can't, this is why this cannot be a true experiment. Okay. And here's the information on the TV access and crime rates. So again, this is a period of time where there was a lack of TV licenses, so that some people in the United States had access to TV and others did not. And this was a period of like 3 or 4 years. Yeah, 1951 to 1955. So specifically, they wanted to investigate whether crime rates, and again, it was specifically larceny, whether that crime was rising in the cities that had recently acquired television, okay? Again, this does not fall in the true experiment category because there was no random assignment, right? There was no manipulation as to which cities had TV access. So if a city already had more crime than another, and then we have a TV difference here, there's kind of a confounding variable as well. But they're taking advantage of this historical event to see the impact. What do you guys notice from the graph?
It doesn't seem like it's that different. They seem to be like they're on kind of a similar trend.
Yeah, definitely. If we look at 1951, which is this like pre, year, so to speak. So this is the larceny rates for both groups. And then you could see this green line, they then got TV access in 1951. So there is an increase right here in the rates of larceny. But if I follow the line, the increase really starts closer in the 40s and then just continues to steadily climb, right? This yellow line shows those who only received TV in 1955. So this is when they received TV. But what else do we notice about this curve, or this line, I should say? It was fairly flat, right? So the level of crime, was again higher over here compared to this dip, and then was slower to rise, and then they really matched each other up almost identically post 1955. So could you make a claim that the difference in larceny rate is due to access to TV? How do you guys feel about that?
That would be not supported claim.
Yeah, it'd be hard to say that caused a significant increase. I agree with you. There's this is a tough one. And I think this study specifically is more problematic in terms of the design of the study, because you're looking at different cities, you're looking at, a different factor here on the front end, regardless of what's happening between these 4 years. So a little trickier to say. Okay. So let's talk for a moment about internal validity and quasi experiments. So we've talked about all of these before, but again, you want to minimize selection effects, right? So using matched groups as much as possible is going to be useful. You can do a wait list design. So again, being mindful of the cosmetic surgery study, you can look at groups who want to be part of the experiment, like the experimental group that are getting the treatment, but that are not quite in it. So that means there's a similarity between those participants. So that would be a better matched group for your control. They're not actually getting the intervention, but they're interested in it, right? So more matched. You need to be more mindful of design confounds. You want to try to rule out as much as possible systematic variation, so that somehow there's some variation within the study that's not caused by what you're manipulating or what you're looking at, but something else. So again, in the idea of crime rates and television, which city you're measuring is going to have an impact. That's one of the confounds, right? Regardless of exposure to TV or not. Threats for maturation, again, using a comparison group is going to be huge. We saw that again in the cosmetic surgery, right? So you're looking over time, what does self-esteem look like for both the comparison group and the intervention group, so that if you're just improving self-esteem as you get older, that kind of maturation threat would be identified. And then you want to look at history threats. So again, using a comparisons group is going to be quite huge. And you want to make sure that, if somebody is, they're going through some sort of historical context, that you have a comparison group that's matched in that way. Regression to the mean is something you need to be very mindful of as well. So this is the SAT scores and there's a pre-test and post-test, and then several different groups. Again, this is due to multiple random factors. So this is non-Head Start right here, non-Head Start studies, not in the study, okay? So these are just numbers that have been aggregated by the SAT department or Department of Education, a pre-test and a post-test there. And this is again on SAT score, so before they took the SATs and afterwards. This here is the matched non-Head Start students extreme low group, and there's a mean at the pre-test and then that may have regressed up. So they were in the lower group and they regressed to the mean. And here's another one. This is the matched Head Start student extreme high group mean at pre-test that may have regressed down. So regressing down to the mean. And again, this is Head Start students that are not in the study. Bottom line for this is if you do a pretest and post-test and you get a really high score or a really low score, chances are if you retest, it's going to be closer to the mean. It's just going to average out. So really high scores drop down, really low scores go up. This is what this is saying. But again, you can refer back to when we talked about internal validity. What is the threat of regression to the mean? You'll get more info. Okay. Attrition threat. You want to make sure that if somebody is dropping out of your study, that it is not a systematic attrition. You want it to just be truly random. Did people who complete the study vary systematically from those who did not? So for instance, in the cosmetic surgery study, did the people who dropped out of the study lower in self-esteem at baseline, thus inflating the results? Okay, that could have been one of the situations. You want to make sure to look at testing and instrumentation threats. Is there practice fatigue? Are we looking at different tests? Are there different, I think we talked about different versions of the test to make sure all is well. Is there different coding that's being done? Now, most of this we're looking at in terms of self-report, right? So it's a little bit not as much of an issue, but if you were doing an observational study, you'd want to make sure everybody is observing in the same way. Again, to minimize all that, you want to use a comparison group as much as possible. With observer bias, demand characteristic, and placebo effect, as often as possible, you want to use a double blind or a masked study so that you, the researcher, are not changing the results because of what you expect to see, and the participants haven't figured out what they're supposed to do and changing their behavior because of what they expect to see. Okay, so really all of this, same as with a regular experiment. You just need to be mindful of all the same threats. All right, so let's talk about now balancing our priorities. Like, why do we even do quasi-experiment? What's the goal? And yeah, all of that. So first example is that the real world is filled with quasi-experiment opportunities, right? It is far more likely that you can run a quasi-experiment than a strict experiment where you have a random assignment. It requires far more organization and resources than are available in some situations. Okay, so some of the real world opportunities, like I just talked about, is the TV and crime rates, right? There was a historical event that allowed for an inherent comparison, and so it was taken advantage of. Same thing with the judicial decisions, looking at a judge and their decisions over time. There's a real world opportunity to actually mark that, and you know what time each case was presented and whether the results were favorable or not. So you're setting up a study because in a way it's simple and easier to just sit in and observe. You're not pulling people out of their day-to-day lives, to participate in your study. So attrition is also lower because you're just observing something that is naturally occurring. There's also much higher external validity because if you're taking situations that are naturally occurring in the real world, chances are they're going to generalize to the larger population more easily than creating more of a laboratory, experience. One of the other big pieces is how we run experiments in some cases brings up a lot of ethical issues, okay? So if you are testing out a specific treatment and there's benefits to that treatment, and then you randomly assign people into a control group, those people are not getting the benefits of the treatment. So inherently, when you think about doing good and avoiding harm, it gets into this gray zone there when you have a control group. So, research on smoking is kind of a big example. Your textbook goes into a lot of details about that. So almost everything that we know about the health effects of smoking come from quasi-experimental studies, not from true experiments. They didn't randomly assign people to, you start smoking, you don't smoke, now let's look at your health factors, right? They were looking at smokers and compared them to an age-matched group, right? To see if there's inherent differences in health, okay? But it'd be incredibly unethical to subject participants to a condition that we know is harmful, right? the same way, if you know, texting and driving is not a good idea, you can't really randomly assign somebody to be like, I want you to text the whole novel as you're driving down, stop and go traffic. We're not doing that. We're taking situations where it's naturally occurring so that we can learn from them. Okay. Another huge advantage is construct validity is usually very well defined. So the cosmetic surgery example, participants really did or did not undergo surgery. It wasn't kind of a fine line, well, sort of, right? No, they either did or they did not. So very clearly delineated. So statistical validity can then be enhanced when you're using a quasi-experiment, because researchers don't need to incur the time and expense in manipulating variable, right? We're going to do all these people with this particular independent variable, then we'll take it away, do all of these people. So sample sizes can be large to then increase the power. Okay. So back to the original question when we started this lecture, are quasi-experiments the same as correlational study? They can look the same, but they do have several characteristics that they have in common. So in independent group designs, you're actually kind of running through a correlational study because you're comparing two or more levels of an independent variable. Just like in correlational studies and in contrast to true experiments, quasi-experiments do not use random assignment. So that is a big key, okay? You look for pre-existing groups, they've already been self-selected, and that's who you decide to study. But unlike correlational studies, researchers conducting quasi-experiments use a variety of techniques to enhance internal validity and perhaps give evidence of causal claim. The perhaps is kind of an underlying word here because some of them, there's too many factors. You can use match groups again, or comparison groups in some way, but the line can be really fuzzy. So it's less important than addressing other validity concern. So aiming for causality is going to be more challenging when you're using quasi-experiments. Okay. Let's talk about the difference between small n design and why we would want to do that versus the large n, because all along I've been saying large n, you need to have a large sample. You can't have a sample of 10 people to represent your whole thing. But there are some situations where that's beneficial. So in a large sample design, your participants are grouped. So the data from an individual participant are not of interest by themselves. It's the aggregate that we look at. So they're represented again, the aggregate would be this group average. In the small n design, each participant is really treated as a separate experiment on their own. So you usually end up using repeated measures. So think of our judge example. They probably didn't have 500 judges, right? They may have had 3 or 4 to see if this pattern held true. And they had them do it over and over again. So they measured day after day. Are we seeing these patterns repeat themselves in terms of the parole piece? Yeah, that's what I want to say about that. All right, so studying only a few individuals can be very helpful. So if you look at research on human memory, and if you've taken a class, like a basic psych class, you've probably heard about this individual we'll talk about in a minute. Research on split brain, right, where the corpus callosum has been severed. You can't really start saying, we're going to do that to 500 people. That's not happening. So it's really almost more of a case study. You're looking at a few individuals that have undergone this treatment to see what patterns have emerged so you can learn more about the condition or the intervention. So specifically for this one, we'll look at 3 small n designs, and then we'll evaluate others. There's Piaget in there as well. We'll talk about that in a minute. Okay, so this is, again, a case study to show separate memory system. This is Henry Molaison, who's often referred to as HM. He was suffering from repeated seizures. And part of that, it was obviously impacting his life. The thought at the time was, how about if we remove the front half of his hippocampus on both the right and left side and see if that helps in reducing the seizures. Okay. So little information about him. It significantly reduced his seizures. So in that sense, it was very successful, right? The goal was reducing seizures. That happened. However, as he was recovering, his family and medical staff noticed that he didn't recognize the nurses and doctors caring for him. He remembered his parents and he could recall many memories from before the surgery with varying levels of detail, but he had seemed to lose the ability to learn anything new. So doctors and nurses coming in, this was not crystallized in his memory. It was new memories that were forming, and that's what he couldn't hold on to. So by studying HM and patients with similar surgeries, the researchers were able to learn that bilateral hippocampal lesions do not affect intelligence or personality, only the ability to form new memory. Okay. So they continued to study HM for more than 40 years. Again, this is a strong case study, small n, we got one dude, right? But 40 years of studies to learn more what's going on when you have that type of surgery performed. One of the examples they did is they taught HM to trace a star pattern with a pencil while seeing his hand only in a mirror, okay? So you see, no, I'm pointing at my own screen. You're not gonna be able to see what I'm doing. So this is a screen right here. So it doesn't allow him to see directly down what he's doing, but he's looking at a mirror and he's learning how to trace the star, okay? So that's one of the cognitive tasks that they developed to see how much he was learning. So they did multiple repeated trials to see if his performance was increasing. And then they compared it to a control group that had an intact brain to see if the differences were, pretty significant. But the interesting part is each day when he saw the task, he would say, oh, I've never seen that before. I've never encountered this task before. So it was like a brand new task every single day because there's no crystallization of new memories. So in this particular study, we're balancing the priorities of the case study research, right? We want to understand the impact on cognitive function within these individuals, but again, it's not feasible to have a true experiment. So you create a control for some of the task, right? You can have non-brain impaired individuals come in and do the same task and see if they get better over time, and see if in fact HM is not getting better over time. That's really showing you that the new learned memories are not sinking in, right? Like he's not improving, his performance is not improving as they go through. So, that can be really helpful, especially if you're looking at a specific case that is very rare. So just like when we talked about quasi experiments, that you're taking advantage of something that's naturally occurring in the world, small n studies are also that. They take special advantage of unique medical cases or unique cases just in general to learn from it. So again, it can generalize when someone else gets a similar condition, they have some knowledge about it. The disadvantage, again, is that, again, Henry HM specifically, his cerebellum was also damaged from anti-seizure medication because he had been on them for so long. So his case was already kind of layered, right? It wasn't just that he had had the surgery. It was also that he had other mental and, actual cerebral impairment because of the long-term effect of the medication. So that does lead to an internal validity issue and will be a disadvantage in terms of external validity, because when you're trying to generalize this surgery to another group, they may not have that same level of impact due to medication. So when you're looking at research on split brain, it's another case, it's when a patient's corpus callosum is severed, okay? So it's done surgically as a last resort for some patients with very severe seizures. So it allows to control the electrical storm that happens between the two hemispheres. But aside of this is that the two hemispheres of the brain no longer directly communicate with one another. So in 2005, there's a group of researchers that looked at what happens when visual information was sent only to one half of the brain, especially allowing them to study the two hemispheres of the brain separately. So what they did is they used a device that presented participants with different images to each eye. So you could see one eye is seeing the saw and the other eye is seeing a hammer. But again, there is no crossover that is happening because there's the severed corpus callosum. So, yeah, so you can see what they saw. So one of the several notable results of the study is that when patients were presented with an image to only the left eye, they were unable to verbally report what they saw. And that's because language processing is in the opposite hemisphere. This problem did not occur when the image was presented to the right eye, thus confirming that speech is usually produced by the left hemisphere. There's tons more data in the textbook about this specific experiment, and there's just fascinating results that come of it. So take a peek at it if you have a chance. Again, when you're balancing priorities, understanding what's the impact of having a severed corpus callosum is helpful. It's something you want to know. But now, how do you do that, right? You're not going to randomly sever someone's corpus callosum unless there's a medical need for it. That would be highly unethical. So you can look at, comparing it with a control group, seeing how they're able to perform compared to somebody with an intact brain. You could do repeated measures, right? You can look at strong manipulation. So tasks that they use would be easy for normal controls, but they were impossible for split brain patients. So you could see the difference between the two. And then you can make sure that the results are replicable, meaning other patients that have a similar surgery that has happened, they are seeing the same results in terms of these cognitive tasks that are being asked of them. Again, this is taking advantage of the small n case. These are more case studies because you do not have access to multiple individuals that would fit this criteria, right? It's just not going to happen. One of the disadvantages, though, is that these special cases are not really representative of the general population. They're far more limited. So these patients all had severe epilepsy before the surgery, I should say. But can we generalize these results to other people? So one thing is, does every type of seizure disorder mimic one another and is the same in all patients? Or are we going to see some variability because of that? Okay. Oh, animal studies. Let's talk about that real quick. So when combined, so you can look at the greater relevance for results in the population, then you can also combine it with animal research and animal studies to see if the same is happening. So you can do brain imaging to check on normally functioning participants, and then you're able to make more of a case for it. So again, evidence from animal studies and people born without a corpus callosum, that allows us to see if the same patterns are emerging. Okay. This is behavior change studies in clinical settings. We're looking at 3 specific small n designs. So this is the efficacy of treatment or intervention. Let's talk about this particular study. The first is an example of a stable baseline design. So it's a study where a researcher observes a behavior for an extended baseline period. It's the section right here. All of this is the baseline period. And then this is the expanded rehearsal. We'll talk about that in a second. So if the baseline is in fact stable, which in this case it is, then the target behavior only changes after a treatment. We can be more certain of the effectiveness. So in other words, if you were, actually, that's a good example. Some of the medication for any psychological medication, right, psychotropic drugs, may cause you some secondary effects. Sometimes it's tremors, they're called extrapyramidal effects. You can introduce a medication, right, to try to inhibit some of those side effects and make it more comfortable for people. So if you were doing a specific cognitive task at baseline, right, you would be checking to see how are they doing when they're at this baseline period. Are they able to perform the cognitive task? And you would want to see a fairly stable result, not super random where it changes every single day. Then you introduce this new medication to try to inhibit some of those side effect symptoms. And if you see a massive improvement in the task, then you know that it was because of the introduction of that medication. You're able to look at causality a bit better. Okay. So this is specifically with Alzheimer's patients. So they're looking at the effectiveness of an expanded rehearsal technique to enhance word recall. And again, specifically in Alzheimer's patient. So there was a low stable baseline, as you can see right here, right? They weren't able to recall all that well. Once the new expanded rehearsal technique was introduced, you can see recall rapidly and dramatically increase. This is a significant change from this baseline. So measuring the stable baseline for an extended period of time is crucial in terms of the internal validity, because then you can say that the intervention is actually what led to the change. So it doesn't show that it's just, maturation. It's not regressing to the mean. It's actually the intervention that's having this particular impact. Okay. Excuse me. In a multiple baseline design, you have all of these. So again, they're measuring baseline and then introducing a specific treatment. So this was designed to teach a developmentally disabled 12-year-old girl to refrain from engaging in distracting behavior. One was touching her face, touching her hair, and grabbing objects kind of randomly. Again, small n, right? This is just one individual. So first, the baselines of 3 behaviors were measured over the course of several days, and this is the number of times the behaviors occurred. Are we seeing a stable baseline here? Would you say this is a stable baseline in either of those conditions?
No.
It's not, right? It's variable, okay? So that's one thing to note. But the biggest change will be the number of sessions, and as you can see here, how it works. So the first therapy session, only one of the behaviors was targeted for modification using an overcorrection technique. So sitting quietly with hands on the table for 3 minutes. And then later on, they added the hair touching behavior to try to reduce it. And then lastly, they went to grabbing objects. So you can see this is over time, the number of sessions, right? You see the dramatic decrease here. And once they feel like they've established a baseline in reducing the behavior, they then addressed a secondary behavior. So that's when they moved into touching hair. Then once they were able to establish a baseline that there was a complete reduction in the behavior, they introduced the third one, which was grabbing objects, and so on and so forth, okay? All right. Yeah, that's true. So one of the confounding variables is maybe it's just therapy that's making it better, right? You're having more one-on-one attention and time. But if that were the case, then just having sessions would have improved this here. You see how this is decreasing, but it has not really changed over here or even over here. So we're seeing really that the specific overcorrection of the behavior is what is causing this change. Okay. A reversal design shows effect not due to maturation or regression to the mean. So this is the last behavior change example. In this type of study, researchers observe a baseline of behavior before treatment, then they observe the behavior during treatment, and then they remove the treatment altogether to see whether or not the behavior reverts back. So first we note here the baseline, we introduce the treatment, there is the reversal, meaning we just let go, we take the treatment back away, and then we reintroduce the treatment, okay? So the depressive behavior is this yellow line, the green behavior, the green line is coping behavior. So you can see at baseline, very low coping, very high rates of depressive behavior. You get introduced the treatment and we see a sharp increase in coping behavior and a sharp decrease in depressive symptoms, okay? Now you stop therapy altogether, what do we notice? Incline again in depressive symptoms and decline in coping behavior. Then you reintroduce the treatment and then again, we're seeing kind of the lasting effect afterwards. So more detail, this was a behavioral therapist that was helping a woman's family and helping her deal with severe depression following the death of her mother. So the depressive behaviors were high, coping behaviors were low, just as we described. After the therapist showed the family how to better respond to the depressed woman, her symptoms dramatically improved. But when the family reverted back to their original ways of responding, this is the reversal period, there was an increase in depressive symptoms and a decrease in coping. So this type of design, and again, the last piece, which we just talked about, the therapeutic intervention was reintroduced and depression symptoms reduced again. So this type of design is most useful in situations where an intervention might not produce a lasting change in behavior. So again, it would not be appropriate for an Alzheimer patient in terms of learning. This is not going to be real helpful here. But again, this is really showing that the treatment itself is helpful. Now, looking at this, can you think of any ethical concerns in doing a reversal type of treatment?
I feel like it could put some people into psychological distress, or like maybe put them in harm's way due to their negative emotions.
Yeah, 100%. We're using this as the depressive symptoms, but you superimpose this type of research design on anything and it raises some red flags, right? Somebody who is a severe addict, right? Addict tendencies. You work on a treatment and then you remove the treatment and have them just cope the way they do previous to them receiving treatment. That's going to cause a significant increase in risky behavior. So there are some ethical concerns to be, aware of in this type of design, especially. All right, so other types of small N study. One of them is Piaget. Did you guys study Piaget in like a basic, psych class? So Jean Piaget from the early 20s was a developmental psychologist. He was interested specifically in cognitive development in children. So he developed a lot of his theories in large part through careful observation of his own children, right? Small N design, it's your own kids. And he had 3 kiddos. So the idea of conservation of liquid, where younger children think there's more liquid when it's poured into a taller glass. Have you guys done this with nieces or nephews? Right. You can have like a short, squatty cup and it looks visually like there's less, or a tall, long, skinny one, but there's an equal amount of liquid. So this particular theory that he utilized, it's because he saw it with his own kids. Okay. This is another one, Hermann Ebbinghaus. This is probably something you've also heard about in terms of memory decay. So again, experimental psychologist from the early 1900s who was looking at memory. What he did is he made himself memorize a long list of words. So again, small n, it's yourself, to see, and they were nonsense words. So it wasn't like table, chair, like I think one of the, pawn, mip, these are non-words. But he made himself memorize a long list of nonsense words, and then he documented how many words he still remembered each subsequent day. So this is what is called the forgetting curve. And this is still active in psychology today, that we know about memory decay over time. But again, very small n, he was studying himself, right? Pros and cons with that. But it's interesting that that has remained. It's been replicated enough time in larger groups to show that that is actually still correct. All right, so again, we always look at the 4 validities and how are they impacted in a small n design. So for internal validity, it can be extremely high, especially if the study is designed carefully. You have strong internal validity, again, because you're looking specifically at one item, and in smaller groups, there's fewer things to go wrong. In terms of external validity, that can be problematic. It depends on what is the goal of the study. If the goal is to study, like Ebbinghaus, is that I am every man or every woman, and so the way I lose information or decay my memory will be the same as everybody else, that's more problematic, right? Because there could be something inherent about him where he's brilliant, or especially non-gifted cognitively with memory, that would impact that. But if I'm looking at a specific group that has a medical condition, right, or that have undergone a certain surgery, then there's more replicability within that generalizable population. Construct validity, we talked about this a minute ago, can be very high, especially if independent variables are measured really precisely. And then again, statistical validity is not always a key piece of small n designs. And the reason why is you're not comparing statistical scores necessarily. It's really more of a case study to learn from this particular example. So that, it kind of hit and miss with that. Okay, questions about this chapter? Lots of good info. Your textbook also has, there's a whole section, I didn't even talk about it in this, but an example of the Affordable Health Care Act and how people are now seeking medical attention after they now have insurance. I thought it was pretty fascinating. Okay, that's all I've got for you guys. So I think I'm meeting, Ashley, am I meeting with your group? Yes.
Yeah.
Okay. All right. So you guys stay on. Everybody else, I will see Friday. Bye-bye. All right.
Hello. Okay, so I know
Stop recording.